So our topic and presentation title is First Do No Harm. Lynne Murray-Ryder, RDH is a zealous dental hygiene advocate who, enlisting anyone in dental conversation from patients and colleagues to strangers, lauding all things dental hygiene. She has presented to community health groups, dental hygiene students, dental offices, legislatures, the Maine Dental Hygienists Association, and the Academy of Laser Dentistry. She has served on several boards, including Contemporary Oral Hygiene Magazine and a Maine-based nonprofit, whose specialty was public health dental hygiene and an outreach business. She served as clinical dental hygiene instructor at Cape Cod Community College and as a child advocate for Spruce Run, a safe shelter for abuse. Lynne has been a vital leader with the Maine Dental Hygienists Association for over 20 years, generously serving as Maine's dental hygiene president 3 terms, MDHA CEU council chair for 15 years, and as an ADHA delegate. She is a past recipient of the Maine Dental Hygienist of the Year Award and recognized as the initial pros in the Professional Crest Oral-B Award. Her mania for all things dental hygiene is summed up best by her beau husband, Peter, of 36 years, who frequently says, "It all comes back to dentistry." Give a warm welcome to Lynne.
Loose. Okay, I feel like Scotty beamed me up here. So first of all, the AGD disclaimer. I don't have any financial interest of a product in my talk or any financial liaison with any companies offering grant monies for this continuing dental and medical education program. So I want to thank you all for being here, and I am sincerely humbled that the IAOMT would take a chance and have me speak to all you folks. And I'm kind of glad, in lieu of how the Senate hearings are going, that you've all had lunch and you're a little sedate, so I'm hopefully assured of not too much commotion in the back of the room. In 1981, I had a professional epiphany. I was attending a CEU outside of Boston. I lived on Cape Cod, and the course presented riveting information that I had never heard anything like it before. And as each hour passed, I was totally convinced that what was going on with my patients and them constantly returning with infection had everything to do with the material that I was hearing about. It wasn't that I was a bad clinician. I'm not going to say I'm the greatest. It wasn't that my patients weren't doing their self-care techniques. It was the fact that there was infection present that wasn't being identified. So that day really was a pivotal day in my dental hygiene career. I vowed that at that point, I was going to aggressively diagnose, and yes, I'm using the D word, dental hygienist, diagnose periodontal disease with identifying the infection. At that point, it got a little bit uncomfortable because several dentists in the room got very animated. Sometimes it's hard to say, hey guys, this is a window now. You know, who are you to tell me this is a window? And the speaker waited for all their diatribes. Some of them were not very pretty. And he very humbly and calmly said, yes, what I've told you is true. These severe periodontal defects did grow bone back. And he showed before and after radiographs. The speaker's name was Dr. Paul Keyes, and he forever changed my life in 7 hours. And I will be forever grateful. We know that dental disease impacts systemic health. We know that so many different links are being attributed to the presence of the periodontal pathogens. And in addition to the ones that I've listed here, we know they've also been implicated in stroke, heart attacks, complications with joint replacements, adverse therapy outcomes. So most likely, the pathway for the periodontal pathogens is prolonged inflammation. We know there's a constant assault on the tissues, the jawbone, leading to an increased permeability of the tissues and subsequent increased capillary fragility. inviting the bacteria via the host bloodstream to produce havoc in the presence of the host immune system. I'm a little winded just saying that. But I wanted to have that all down because it's such a cascade of events, and I think we have to have an appreciation for that. So what I ask you today is, if the implications for what we're doing and mucking around in the mouth are this serious, wouldn't you want a comprehensive, supportive, and early approach to produce the most preventive outcomes? It just doesn't make sense anymore to keep doing what we've been doing. So we might want to begin by asking the questions rather than making statements. Are your gums sensitive? Have your teeth shifted in position over the last few years? Do you have breath concerns? Do your gums bleed when you brush? And I have a tendency to say to my patients, you know, if you were washing your face or washing your hands and you started bleeding, wouldn't you freak out? They kind of think about, oh yeah. I said, then why do you accept a little bleeding in your mouth as being normal? And we also want to ask them too, about issues with dry mouth. That seems to really be coming to the forefront. And what we're seeing happening is so many patients are being inundated with information about the water consumption. And so now it's really throwing off the minerals in the mouth, which is alluding to having the pH thrown off. And we also know that a lot of bottled waters, you might want to test it for yourself if you haven't. A lot of the bottled waters are turning out to be fairly acidic. So that's something else to keep in mind with our patients. And the last thing I found really fascinating is in looking up some of these conditions associated with periodontal disease. There's been some very limited, of course, post-mortem studies with Treponema denticola, which are spirochetes. And they have found that these patients who had a diagnosis of dementia, all of them, they were looking for a common link. Was it chronic smoking? Was it chronic alcoholism? Was it chronic drug use? They all had oral spirochetes in their brain tissue. And more recently, it's been found that P. gingivalis has byproducts that have been found, and they're noting those patients post-mortem with higher correlations of Alzheimer's and the incidence of the Alzheimer's disease. And I thought it was just kind of cool. I did a PubMed search of inflammation and periodontal disease, and they had listed 8,740 articles. So we have this body of evidence, and what are we doing? Picking, scraping. So my goal today for all of you is just to share that I think dentistry is super preventive, and we're missing the boat if we don't turn the boat around. And I think dental hygiene in particular, that discipline, is first do no harm. I feel bad because I would love to take any questions at any time, but time doesn't allow for that. So what does the typical dental appointment look like? And I'm not saying that any of you by any means are typical. If you're here today, you've got concerns about mercury, you've got concerns about fluoride toxicity, you're not the typical dental office. But are some of the things that we do, we fall back on old habits. So hopefully today I'll give you some ideas about how we move forward. So you do your usual clinical observations, your RBL, your radiographic bone loss, you're looking at your restorative charting, usually done by the doctor, your periodontal charting, which, as Bill Lander said, with the famous notch stick, which he's so elegantly coined. You're looking at erosions, wear facets, color of the teeth. You're doing an airway assessment. You're assessing if there is malodor. And I thought it was really cool in the presence of malodor. There are different smells, obviously. We smell them all. None of them are too pleasant. And I was surprised that they actually have scientific names attributed to some of the odors. And one of them, for instance, methyl mercaptan. Well, that doesn't sound too bad, but that is the smell of feces. So I had, there'll be a handout just passing around. It's kind of interesting, the elegant names that they've attributed to these smells. So generally, once you've collected this data, what do? Okay, am I going to give the patient home care instructions? Probably. Am I going to assign a periodontal case type? Most likely. And when I was looking up some information, I just came across the AAP has not review or changed their case findings since 1999. And so starting in 2015, there was an international workshop, and they have now revised the case types, which was just published in June 2018. You can look it up in the Journal of Perio. So I went to it expecting, I don't know, something grandiose, and it's still 1 through 4. They did add periimplantitis. They did add risk factors, smoking, risk of diabetes, and other conditions such as cardiac to that. And they now have a grading system. So they have A, which is low, which means the last few years the periodontal condition hasn't changed much, moderate, changed moderately, and then severe. So to me, at this point, and with all due respect, because I don't know if there's any periodontists in the room who are very beholden to the Academy of Periodontology, but I didn't see any mention of any bacteria. And we've been looking at the bacteria now for 30-something years. As I said, I'm not very good at math. I had my first course in that in 1981. So why aren't we doing something different? So it leads me to one conclusion, is we're still rendering and offering supervised neglect. Because in my opinion, I'm going to be bold enough to say it, this is Mary Lynn and her little world. If I'm not turning over every stone when I see that patient, I don't feel like I deserve to see that patient. And so hopefully we'll instill in you some ideas or maybe some different roads to take. So one of the things is I think we can build a patient profile. So you're going to do your usual dental, but also to individualize the patient treatment plans based on what you're seeing in the patient's mouth that day. Are they having fruity breath? Have they told you they're under stress? Have they told you they're on a sugar binge? And I think that in doing so, in mirroring both medical and dental, we now are going to come up with a more scientifically sound, holistic, truly holistic approach. So what are some of the things that we can look to? We can look at vitamin D levels. We know that vitamin D, sorry, I'm quick with my fingers, my bad. Vitamin D, most of my patients are very deficient in vitamin D. And if you don't feel well versed about it, you can just take a course or two. You'll get right up to snuff on vitamin D. The problem I have with vitamin D, the levels are all over the map. You ask them, well, what did your primary care think when your vitamin D was 20? Oh, it was a little low. Well, the range is 30 to 100 in most average cases, although we saw one last week. They said the range was 25 to 50. What's up with that? I've never seen a lab that has used a range like that. And they said anything over 50 could be toxic. And I would dispute that as well. We can also look at the patient's profile as far as have they had other infections? Have they told you they've recently had a heart attack? Because I think CRP is very important. We know that CRP is a protein that is produced in the liver, and it's considered to be an inflammatory marker. And we know that the CRP level is going to rise as infection in the body rises. Might be coming from the mouth, it might be coming from a different part of the body. You're not there to discern what that CRP implication is, but it's just another piece of the puzzle in talking with the patient. Gee, has your doctor talked to you about a CRP test? If the patient says, geez, I'm pre-diabetic or I've had different things going on, has your doctor talked about an A1C? A lot of them will do a fasting blood sugar, and I think it's really easy to cheat in 24 hours, 48 hours and be really good. So when I go get that blood fasting, doctor's like, okay, yeah, you're looking pretty good. But it's really hard to cheat over 3 months. And so that's why I prefer the HbA1c, because it's looking at that what the glucose is doing over 3 months. And also, just an aside, getting back to the CRP, 50% of the people that have a heart attack or stroke do not have high cholesterol levels. So a lot of literature is pointing to looking at possibly the highly sensitive CRP score as a better indicator of future disease. And you're not going to use, like I said, all these tests. You're going to tailor it to every patient. I had a patient that she came in She expressed being extremely stressed over work. Her husband wasn't well. She wasn't eating the best. And she just said, I'm totally exhausted. Like, I don't know how I function every day and get out of bed. One look in her mouth, the tissue was red, it was bulbous, it was boggy. I was getting like mega bleeding scores. I'm like, okay, you know, something's wrong here. And I said, rather than do anything else, I said, I want you to get off to the doctor. We're going to have an A1C, a CRP, and a vitamin D. I just threw them all in there because I didn't know which way this was going to go. So she came back, her vitamin D level was low. Her HbA1c was 13.5. Her doctors then said to her, I don't know how your hygienist knew you had diabetes. I didn't know what she had. I didn't know she had diabetes. All I knew is something was drastically wrong, and I wanted that information. So since then, obviously, she's been put on a program. She's doing much better. Bleeding scores went way down. We had a lot of improvement in the tissue without doing a whole lot of therapy. I had another patient that had 2 periodontal defects, 14 and 15 and 2 and 3. And she was awesome with her home care. I couldn't ask her to do more. It hardly would find any biofilm in there. So our pockets would vacillate, and every now and then, you know, just you get that shiny red, and you're like, what is up? I'm not finding anything here. I just don't get why this tissue isn't healing, and the pockets are improving. So I had her do the CRP, and it came back that it was 4. Well, 1 or less is considered low or good. Even some labs will say 0.8. And she happened to work at the hospital, passed her cardiologist in the hall and said, hey, I just had a CRP and it's 4. He's like, well, you need an appointment. Let's get you in and see me. The next day, she woke up in severe pain. Her husband rushed her to the hospital, and she had her appendix out. She was close to being septic. So again, I didn't know what was going on. All I knew is it was reflecting in the tissue. So my emphasis again, first, do no harm. So this vitamin D council is something that we refer our patients to on a regular basis because you get put in a really awkward situation with vitamin C, and we shouldn't. And I love what Dr. I hope I don't say his name wrong, Hins said this morning, how really they don't know anything about nutrition. It's not their fault. The medical schools are run by Big Pharma. That's what they learn. They learn to give medications. I just wish they would turn that piece over to someone else and say, yes, it does have importance, and hey, let's work together. So when patients have anything going on from breast cancer to heart disease, or I just want it for their general wellness, or their child is autistic, I refer them to this site. I say, read it, and then go have a dialogue with your physician, and let me know how you make out. Most of the time, if they're seeing a chiropractor or a naturopath, they've had a vitamin D level done, and it's a non-issue. So the Vitamin D Council, as I said, there are many links there that you can associate with vitamin D. We know that the higher incidence of infections are being linked to vitamin D deficiency. We know that vitamin D modulates your T cell responses for your inflammatory properties, which boosts your immune system. We know that vitamin D has also been linked to the production of cathelicidin, which is an antimicrobial peptide. And cathelicidin is kind of cool. It serves a critical role in the innate immune system, which protects you against bacterial infections. We also know that the cathelicidin, the AMP peptides, often hang out in white blood cells, and they actually have the capabilities of warding off gram-negative bacteria. Well, what are we going to be looking at? Gram-negative bacteria. So really, in my opinion, I think that vitamin D exhibits a broad-spectrum antimicrobial activity. Not everyone, though, will benefit from vitamin D, and I will speak to that in a bit. The gingival epithelium is part of the innate immune system. We know that the AMPs are found in the chemical barrier of the epithelial layer of the gingiva, but there are also 2 other critical layers. There's physical barriers, where that's what the tissue presents with. The chemical barrier, where the whole inflammatory markers and your cytokine, your pro-inflammatory cytokines are hanging out, as well as the immune barrier. So if vitamin D is so essential, I want to know, why aren't we having everybody tested? The other thing that'll drive you crazy, at least it drives me crazy, is when they say, well, I'm outside in the summer, so I don't really need that. I'm like, are you running around naked? You know, do you wear sunscreen at all? And they find that people even down to Florida who can be in the sunshine all year long are also deficient in vitamin D. So I think it's more common than not. And I just wish it would become a standard of care with our docs. So I found this, and I thought it was really cool. Over a 16-year period, patient records were reviewed at the University of Iowa Hospital and their clinics. They looked at 74,000 patient charts. Of that, there were 128,000 blood serum levels. Of that, I think it was 840, don't want to tell a lie, 780 of them had vitamin D levels of 80 or higher. So we go back to the range, 30 to 100, 100 being top of the scale. When your children are being tested in academia, you want them down here or you want them in the 100th percentile? Just throwing that out there. And there were 89 patients who had blood plasma levels of 120. Of those 89 who were considered to be in the toxic range because they were 120, only 4 of those patients presented with toxicity symptoms, and 3 of them, it was because they were dosing wrong. A lot of patients you'll find when you start getting them on vitamin D, especially if they're older, we'll have them do the liquid because they absorb it better, they don't have to break the caps down, and they'll go for the cheaper one. Well, some brands say 1 dropper is 5,000 IUs, while other ones will say 1 drop is 5,000 IUs, and they found that's where the majority of the issue was. So the authors concluded that vitamin D toxicity is very rare. Tongue diagnosis, we know that the tongue is a map of the body in Chinese medicine, and they use it as part of the healthy checkup. I'm not a tongue expert by any means. I definitely record what the tongue is looking like, what the color of the tongue is reflecting. But, and I'll share, and I'm oversimplifying now, I'll let my patients know if I see a pink tongue, oh, things are, you seem pretty healthy. A brown-gray tongue is related to stomach issues. A yellow, gallbladder, could be liver, could be GI tract and inflammation. And whitish on the tongue, they say that there's probably a viral infection, cold, allergies going on. And reddish purple, bluish purple, which I have never seen, says blood stagnation. And anything like that, I typically, like if there's heavy fissuring in the tongue, I know there's some kind of vitamin and mineral deficiency. I'm going to refer them out and say, I really want you to check base with your chiropractor or your naturopath. Okay, take me a minute to do this. I wasn't sure if the audio would play or not. So how many work with a microscope? Okay, cool. So we've got a few. So this is what we're likely to see on an average day. We get a patient in, whether it's a new patient, an old patient. My first thing after I do my head and neck, oral cancer screening, done their blood pressure, done all that, lean them back, look at the tissues, pull out their tongue, then I'm going right for the gusto. I'll go for all 4 quadrants and the top back of the tongue that I can do without seeing their lunch. And also, I will do it on edentulous patients too. We try and encourage our patients in dentures to come in once a year, but that doesn't always happen. But when they do come in, I'll take it on the maxillary edentulous ridge. I do one on the mandible, and I do one on their tongue because they can still harbor a lot of yeast from those dentures. So what you're seeing here is these little wormy things. Those are all spirochetes. They come in 3 different shapes. They're small, medium, and large. And the small ones are apparently the more acute phase ones. And then these circles here, there's quite a few of them, those are all white blood cells. So the good thing is white blood cells are present, so they're fighting an infection. Cool, immune system's working. But their presence means there's a whole lot of infection. So my concern is, what if I didn't see this? And I've done my gum measurements, and I do a prophy, and, oh, maybe you had a couple of 4s and 5s, so we're going to get you back for a root debridement. I'm dumping all that infection into their bloodstream. We're relating this bacteria, Treponema denticola, those are the spirochetes, were found post-mortem in tissue of people that died and had dementia. So I don't know why the Academy hasn't added this into their protocol. I think it's a shame, and I'll keep saying it, I think it's neglect. So this is yeast. Wanted to give Bill a shout out because I stole his slide from Oratech. So you can see that transparent pod. I thought it was kind of cute because it goes up, kind of makes it look like a snake. See at the top of the screen, his eyeball running around saying hi. So the yeast are actually all these different pods, and it won't be particularly, like you'll see on here, here's a short pod coming off, and then you see these little pearls inside. I've never seen yeast move except for once. We were at a continuing education in Maine. This hygienist walked in off the street. Can I take your course? She was from Rhode Island. Yep, great. Happened to be visiting or something. And she said, was talking to Bill Landers, and she's like, I had this perio surgery here, and ever since I had it, something's wrong. Sometimes it bleeds. Sometimes I've got a funky flavor in my mouth. You know, I really want to see what's going on there because I've been back to the periodontist twice. He repacked it, and it's not feeling any better. And she ended up telling someone else that she was nursing. So off we go. I don't know why I did that, but I'm a lot of French too. And she had to leave. So I'm dating myself because this was before cell phones, okay? So she leaves. Bill's got his microscope up at the course. And we come back from lunch, and as I recall, it looked like a big donut. And those little pods that you saw, I don't know if I can go back, that looked like peas in that last film, they were dropping down into the donut. I mean, literally replicating. And he said, the yeast, I don't know if I can make it work again. The yeast knew so well that it was not long for this world, so it was trying to self-sustain itself. And he said, I've never seen this before, and we probably never will again. So it was really cool. Usually when I see yeast like this, you're going to see these transparent pods. And usually what we'll ask the patient is, geez, do you have a problem with yeast? Oh, yeah, you know, I suffer from yeast infections. I don't have one right now. But yeah, it's always been an issue for me. Typically, we'll recommend baking soda. We'll recommend lemon or Bragg's apple cider vinegar in their water pick. And definitely to not do sugar, you know, for 3 to 4 weeks. Of course, some of them are going to roll their eyes. And then I let them know, you know, I can do my part here for your mouth. But again, I refer back to your naturopath. I have found out, and I did not know this, so I'm grateful to Shelby for kicking me in the pants and getting me to do this. And they're now thinking that an acidic environment in your mouth will increase the mercury release in the fillings. So I think an acidic environment isn't just important for decay rate and periodontal tissue health, but now I think here's another reason why you don't want to have an acidic mouth. So things that you can do, make a recommendation. We're big about baking soda. I say to people, it's biological, it's cheap, everybody can afford it, and it's easy to use. So they brush with it, they swish with it, some will run it through their water pick. Other things they can do, I talk to them about xylitol. I say, you know, xylitol can act like a prebiotic. It works on the biofilm. I have a few patients, and you'll probably get this too. I can't use xylitol. I'm allergic to it. How do you know you're allergic to it? Well, I'm allergic to corn. And besides, I'm concerned about GMO corn, and I know that company, it comes from corn. So I know Lisa quite well from Exlear, one of the reps out of Maryland, and I said, Lisa, you know, what do I do with patients like that? And she said, I'm going to give you just some scientific facts, and you talk to them about it. So what she said was, the xylitol comes from corn cob. Nobody's allergic to corn cob. What they're allergic to is the protein in the kernel. Okay, that makes sense. She said, and we do not use GMO corn. I mean, I guess they have a sworn affidavit or how you ever go. So you just have to believe and have faith. Or people can get their xylitol from birch bark, which is another product that they have, but birch bark's a bit more expensive. So it's up to the patient what they want to do. Also with the xylitol product, an aside, well, let me go back to, in your body, your pancreas produces a small amount of xylitol every day, and you use a teaspoon of it every day in the Krebs cycle. So those patients that say they're allergic, I guess they're allergic to themselves. I don't know. I don't know how they're even surviving, because they, I guess, should be dead, because they should be in anaphylactic shock from having that process go on. But you can't argue with your patients, so you have to work with them where they're at and, say they're all a blessing and just, let it go, which is hard for me to do, as you can probably tell in my voice. There's also Theodent toothpaste that has theobromine in it, which has been linked to a high remineralization. And there's Xylamelts, which is a lozenger. And even if you're a dentalist, you can just put it up. The Xylamelts are available at Walmart now, and you can get them on Amazon and CVS and Rite Aid. So it's a lozenger that goes up above a tooth, and it's calcium and xylitol. That's it. You can wear them 24/7. A lot of speakers will wear them when they have to present all day long. So it's not just people that suffer from dry mouth. My sister has sleep apnea, and she said it's the only thing that's given her relief. I have my sister-in-law's stepfather, Charlie, had cancer, and he has that host graft, can't think of it, but where you start rejecting the stem cell, and which was kind of crazy because it's his youngest daughter that was his stem cell donor. But anyways, Charlie had to get dentures, had to have all his teeth out because his mouth was so dry, and the cancer therapy killed everything. And he's just like, and you could see when he would talk, just that red tongue and swollen, and I could tell he was losing his quality of life, and he had been to the oncologist, he had been to several doctors, and they had him on the Biotine and blah blah blah. And I said, Charlie, why don't you just try these? I said, here's a stack of them. I have no idea if they're going to work. And he's like, you gave me back my life. He wears them 24/7. The only thing I'm concerned about, Dr. Levy wrote a book called Death by Calcium. So I mean, when we talk about our choices, I think we have to just say, quality of life versus what he was going through. But I wish the Xylamelts would make a version with no calcium. This test is, if you can't do anything else, I would encourage you in your office to look at this. This is a Banna testing machine for the 3 red zone bacteria. Porphyromonas gingivalis, your Treponema denticola, and your Tannarella forsythicis. And it's $400. And the strips are $6, and the more strips you buy, the cheaper it is. But it's a 5-second chair test. So I'm going to go through these quickly because I understand that I've been a little long-winded. We know that the red zone bacteria are a pretty good indication of further breakdown. So you're not just dealing with what is present in the pockets right now. You're actually dealing with, okay, if they have these present, they're at higher risk to have more periodontal infection in the future. And I also think it gives good fodder for if you say to your patient, okay, I did my 4 samples from here, and they're going to go, well, which one should I take care of? Because I'll really concentrate up here because you said it was up here. It's like, you wouldn't wash just half your body in the shower. You're one whole piece. So and it gets bored, one visit it's here, 3 months later it's down over here. So I think with them, encouraging them, you have an infection, and then relate it back to their family history intake. Hopefully you're asking them, did your parents lose their teeth? Does your husband have gum disease? Is there a family history, like looking for information of cancer, diabetes, arthritis? You're looking for those links anywhere where you can come up with inflammation, and then you're linking this back. Hey, you told me your mother has arthritis and your dad has rheumatoid arthritis. I'm not saying you're going to get arthritis, but you know what? You've got a weak gene there, and now you're showing these red zone bacteria that have been linked to rheumatoid arthritis. You can pass that thing around, Jake. So there's 3 labs you can use. All of them are super helpful. You go online. The first one, the oral DNA lab, is salivary collection. They'll send you the kit. You have them swish with the solution they give you. Spit into it, 30-second swish, put an activator in it, and send it off. The next lab, Hain lab, is paper points. So you're going to take your 6 deepest pockets, and the form is right there online that they'll have you do, and you fill that out. You put the paper points for 30 seconds in the 6 deeper pockets, send that out to the lab. And OMTS, Temple University, is Dr. Tom Rams. He did a lot of work in the early days with Dr. Tom Rams, and he's a periodontist that I truly, I probably sound like I was bashing periodontists, but I'm not. He gets it. He runs that lab. He's an amazing man. And any of those 3 labs, when you get your results back, you call them. You're like, I don't know what to do with this. They're going to talk you through it. So it's not like you're doing this on your own. You're definitely going to be mentored through the process. And, your patients don't know that you don't know. So you just act like you know, and you say, this is what we're going to do. And a lot of times it's like, I'll get in my head, okay, I'm pretty sure this treatment plan, this is going to work. And then maybe it will, and you find great success. And then they come back and you like part of it, but you don't. So you're always tweaking it. And the patients really appreciate, because they tell the difference, especially the patients that you get that come from another practice, because they're like, I've never heard any of this. No one's ever asked me about my vitamin D. I've never seen the bacteria on the microscope, but it makes sense to them. And then they'll come in and they'll tell you, I was watching the nightly news and they talked about, that bacteria could, I could catch a heart attack. And they just start telling their family and friends, this place is different. And that's great PR for the office, but they also sense your passion. So I'm going to go through the bacteria here quickly because they have a high association with many, many links. And my big, I guess my big push is that, again, it's so critical. We know that it's not just dentistry and saving their teeth anymore. It has everything to do with their lives, their quality of life. You could be preventing them from having a heart attack down the road. You could be preventing them from that cliff where you're reeling them back in from diabetes. There have been several studies with Waterpik to show they had these brittle diabetics, and nothing was working. And they just kept giving them more insulin. And finally somebody looked in their mouth and said, oh, wow, they all look like they have gingivitis. All they did was put them on a Waterpik. I want to say it was maybe 15 patients, and all but 2 had improvement in their blood sugar diabetes to the point where they backed way down on their insulin. So getting rid of the inflammation, I think, is paramount. So this is a typical test that would come back, and it's kind of cool because I know you can't see it. It's too darn small. But way over in the left here, this is AA. I don't even try to attempt to say it. I know it's acetoacetomycometans aggregator bacter, something like that. That's the most aggressive. And then the 3 red zone bacteria are the next most aggressive. And why these are getting so much attention in the literature as opposed to these guys, even though these guys are pretty important, is because these 3 red zone don't always initiate a person's immune response. They fly under the radar. They're not always phagocytized. So you can have those red zone bacteria, and you're not always going to be successful with your root debridement. Like, a lot of these don't respond to root debridement, and what do? Oh, well, you got this 5mm pocket, so I'm going to clean this out for you. And everybody's going to look great, for 3 months, 6 months, 9 months. But what are these people doing in 2 and 3 and 4 years? Some of them are coming back and you're having to do root debridement again and again every 2 years. It's because we haven't gotten rid of the infection. And why is it okay for these people to then go in and have periosurgery when they've got all this stinking infection? I think it's time we put our foot down and we just say, we're not going to do that anymore. We're going to test these patients. We're going to establish a baseline. We're going to find out how much infection is there, and we're going to get rid of it. So one of the things that you can do with the infection is to look at the modalities that you have. One of the things we find, I'm going to skip through this, skip through the antioxidants, is to think about going to different courses. I was privy to, like I said, I went to Dr. Kai's in 1981. 6 years later, I finally started working with a dentist who said, yeah, this sounds reasonable. And we were working with the microscope, and then we started doing cultures, and I was using Temple University. And that evolved into, well, I might as well tell you, I went through a fire at work, and a year later we had a flood. And then the dentist went bankrupt trying to sue the insurance company to get back what he lost from the fire and the flood. And he lost. And he was disgusted, and he went off and sold Mercedes-Benz. because he said, you know what, Mary Lynn, I want to do something that people, when they come in, they don't scowl at me and they give me money and they're happy. And he went off and he sold Mercedes-Benz. And he go, oh, by the way, he said, call the patients that have been with you and let them know where you're going to go. So that's what I did. And my first week of work with a new dentist, guess who shows up? The sheriff with a lawsuit because I damaged their collateral. And, you know, we never know what choices we make and where they're going to lead us. But going through something like that, I only tell you that because, you know, our choices really impact other people. And like I tell people, all I ever wanted to do was dental hygiene. I never envisioned a fire and a flood, and I never envisioned having that happen. So fast forward 20 years, newspaper comes. I'm with the dentist that they said they were going to sue. My first week at work, well, the relationship lasted longer, so I guess we did okay. And the newspaper said, oh, we want to interview you because, you know, we hear you doing this microscope thing. We don't really get it. And why aren't other dental offices doing this? So I thought it was pretty neutral in the article. I just said, you know, at some point too, because hygienists will say, oh, my doctor won't let me do that. Or, you know, the dentist will say, you know, I'd really like to do that, but I can't afford it. You know, at one point, my dentist couldn't afford getting me an ultrasonic. So I called the local bank. I said, what's the interest rate? And they said, it's 2%. I said, okay. I came back to my dentist. I said, I'm buying my ultrasonic. I said, I'm paying for it, and you can pay me back like an amortization schedule over 3 years, I think we settled on. And I want 2% interest, you know, for my, and he was great with it. He's like, that is so cool. And I know you're not going anywhere because you want your money back for your ultrasonic. So I actually said in the article, you know, well, hygienists really could take, you know, the bull by the horns and find out what a microscope is and say to their boss, you know what, I know you can't do it right now, but let me do it. And this will be our, you know, our relationship. So all of a sudden, I don't know, a couple of weeks go by. Someone said, Mary Lynn, did you see the newspaper? I said, no. Well, there's an editorial about you. I'm like, okay. I read it. It's a periodontist in Southern Maine and his hygienist, who she worked at my alma mater as a clinician as well. And they basically said that I was misguided. Well, I was fairly devastated. I mean, I can act bold and, you know, but, you know, that's kind of devastating when another professional's bashing you in the local newspaper. And on top of that, no phone call to say, hey, you know, we don't really understand what you're doing. And, you know, we're really hot under the collar about this. Can we get together and talk about this? And then if you don't like what I have to say, go to the newspaper by all means. Well, serendipity stepped in. Dr. Dan Watt, who was the president at the time of the International Dental Health Foundation, who co-founded it with Dr. Paul Kais, he's like, Mary Lynn, this is crap. He said, I'm writing an editorial. Well, we didn't know if it'd get published because typically there's a story and then there's one editorial and they don't let you rebut. But they did. And basically he said, this comes down to money. You know, she's not misguided. There's 45,000 clinicians worldwide that are looking at the microscope, looking at bacteria, incorporating it into patient care. And, you know, I'm behind her 100%. And, you know, that's where it dropped. But, you know, I think if in your heart of hearts, something is true, then you got to stick with it. And, you know, like they said this morning, don't be afraid, be bold, be passionate, you know, believe in what's really important to you. And, you know, your patients are going to appreciate it. And try and think of things a little bit different.
I've never seen.
I just thought that was so cool. And I love it because I think, you know, some days we have the choice to wake up and do things the way we've always done it and say the things we've always said, or we have the choice to wake up one day and just say, you know what? So what if I fall on my face? I mean, we can't be perfect. There's one guy that's perfect and he lives upstairs. And we're never going to measure up to that. So I think going forward, you know, we just be bold, be brave, and there's great resources here of a bevy of people that aren't going to let you fail. So I thank you very much.